It's so exciting to be in front of real people again. I think I'm getting feedback from that one, aren't I? That better? Yeah. So, as I say, it's so exciting to be back in front of real people and a very multidisciplinary group as well, which is always very exciting. And shall I just use that one? Hello, hello. There we go. This one sounds better, I think. It's all right. I can be restricted. It's okay. That's good. Okay. So first of all, kind of welcome, and it's a great honour to be back in Malaysia again. I've lost count of how many times I've been in Malaysia. I think it's well over 10 times now. And whenever I come, I always get such a fantastic warm welcome. So today I'm going to be giving you two talks. One, I've changed the title a little bit, the cause and early management of ankle injuries. In particular, I'll be looking at ankle sprains. And then I'll be doing a second talk, which is going to be a bit more later on in the rehabilitation and post-injury process. So let's just take a look at lateral ankle sprains. I mean, we've had already some very good information, and I'm going to reiterate something which was in one of the earlier presentations. 23,000 lateral ankle sprains are estimated to occur per day in the US. Now that equates to 10,000 one lateral sprain per 10,000 people per day. Now, if you then think and multiply that up in terms of how many years, that's a lot of ankle sprains, and it means that pretty much everybody in the room has got a chance of getting a lateral ankle sprain at some point in their lifetime. Lateral ankle sprains are the most frequent sports-related injuries, again, reiterating things that have been said earlier. It's often defined as being damage to a passive ligamentous structure. So we're not talking about any muscular damage here. We are dealing with ligament structures, which are usually as a result of a forceful ankle plantar flexion and inversion. So we have this traditionally, our common picture here of the ankle position during a lateral ankle injury. And this produces an increase in the mobility or hypermobility between the bones of the foot and ankle, in essence, instability or hypermobility. We can grade ankle sprains in a number of ways. We can grade an ankle as normal, grade 1, grade 2, or grade 3. Grade 1, we're often looking at some stretching and some tiny tears of the fibers within the ligament. And the symptoms are usually a bit of tenderness and a bit of swelling. But really at this point, not really much else needed to be done. Grade 2, we get a larger tear within the ligaments. And the pain, we get much more pain and swelling, much more intense than grade 1 sprains. And these can then start to cause our instability. It's this point that we need to think about stepping in and doing something. Grade 3 is when we have a completely torn ligament resulting in a lot of pain, a lot of swelling, and an awful lot of joint instability. And this is where we really need to think about upping our management even more. Why are we interested in this? I mean, you know, you just go over on your ankle, you're fine afterwards, aren't you? No problem going forwards. Well, we get a lot of individuals with chronic ankle instability as a result of an initial injury. This is not a once occurrence. It is going to then have a much, much longer term effect on somebody's function and stability. So chronic ankle instability is a condition characterized by repetitive episodes of the ankle giving way. And this happens in a lot of cases. So individuals with chronic ankle instability will have this persistent swelling, pain, weakness, reduced range of motion often, ankle instability, diminished self-reported function, and the recurrent ankle sprains. So 40% of people who have an ankle sprain will go on to develop chronic ankle instability, 40%. So this is a big problem that we need to do something with the management. We get these chronic symptoms, and anything which is chronic, we really need to intervene. The other thing which is worth knowing is that if you've had chronic ankle, or if you have chronic ankle instability, this is being a clear precursor to ankle osteoarthritis. Now, we do a lot of work on osteoarthritis. We usually think about knee osteoarthritis and hip osteoarthritis, but ankle osteoarthritis, this is a big challenge, a big problem, because it's really hard to treat, really hard to manage. And it's really a clear message is that people who will go on to get ankle osteoarthritis, usually 10 years younger than if you get knee osteoarthritis, 10 years younger. So we think knee osteoarthritis is a problem. Well, we're getting people with chronic ankle instability going on to get ankle osteoarthritis. So let's have a little bit of a look at the pathomechanics of this. Individuals with chronic ankle instability have been identified as having this mechanical instability, this pathomechanics. So this is related to the structures around the ankle joint. Now, I like putting this image up because we see that on the lateral side, we've got two tiny little ligaments, just two tiny little things there. On the medial side, huge amount of ligaments. So this is really worth noting, and I've presented with many people before, and one individual that I loved presenting with was the late John King from London, and he described these as pieces of string, which I thought was a really nice way of thinking about it. So if these pieces of string on the lateral side break, then there's really nothing to support the ankle in terms of any of the passive structures. We're just relying on active structures. So we get a pathological laxity caused by usually the injuries of ATFL and CFL. In the absence of these intact ligaments, we get excessive amounts of supination and large amounts of internal rotation. So internal rotation and supination are really key movements. We get some arthrokinematic restrictions, hypermobility, talocrural joint restrictions into dorsiflexion. Lots of inflammation and lots of degenerative changes in the ankle complex as well. And it's often the degenerative problems which we will see then much later on in people's lives, where we get formation of osteophytes, and that obviously ends up at our ankle osteoarthritis. So we have this whole progression, this progression of things getting worse over time if we don't manage. We also have functional instability. Now, functional instability is slightly different from the concept of the mechanical instability, because this is largely associated with impaired proprioception and sensation. Proprioception is key. If we don't know where our foot and ankle are in 3D space, we are going to then put our foot and ankle in a silly position again and get another injury. And proprioception, one of the main area, or two of the main ligaments are at the ATFL and CFL. Within those are very, very pronounced mechanoreceptors, which tell us exactly about the position of the ankle joint. If the ankle has now ruptured those, that's gone. We get no information to the brain about the position of the ankle from those structures. We are relying on other structures. So we get this impaired proprioception. We get impaired neuromuscular firing patterns in the muscles because the brain is no longer receiving the information from the proprioception from those mechanoreceptors. So the brain doesn't know to do something with the muscles. So we get impaired muscle function. If we get impaired muscle function, we get impaired postural control. And if we get impaired postural control and neuromuscular deficits, we get strength deficits. So this is a really key part of functional instability, which we, again, can do something about. We can manage functional instability. So I always like to show a couple of injuries at this point. This was a career-ending injury. So it's a very interesting injury, this. We're getting almost a purely inversion injury. So we're getting, you can just imagine what those poor ligaments have just gone through. They are now well ruptured. So now we have another example. This is slightly different. She stretches out, internally rotates her foot, and then starts running on her lateral malleolus. Now, running on your lateral malleolus is never a good idea. So we have these two slightly different mechanisms of injury. We have a purely inversion injury, and then but we also have an internal rotation injury with inversion. Now, I'm going to play this second one again, and I want you to see that she stretches out and internally rotates before contact. Now, if we can do something to change that rotation, but pre-contact, then we can perhaps prevent injury. This is a slightly more recent example. So this happened earlier this year. So we have this, look at that, little innocuous little bang there, and there he goes crying like a baby. Okay, so it must have hurt a lot. So what happens next? So what do we do after these? Well, in this particular case, we have a really well documented sequence of events. So this injury, just shortly after this injury, we end up with him wearing a walker and doing lots of exercises wearing a walker. Now that's really interesting, early use of a walker. So it must have been a grade 3 injury, we suspect. Optimal loading, wearing an ankle brace. So now we've progressed from wearing walkers, getting some loading into the system but stabilizing, into wearing an ankle brace, to then going into full rehab. And if we look at the timeline of this is quite a tight, short timeline to get back to doing functional activities. And in this case, we also use neuromuscular electrical stimulation, which I will mention briefly later. Now, there's a few talks previously that have talked about price. Price is gone. We now have police. And police is different from price because we are wanting to get optimal loading. So what we need to do now, we need to be thinking, in the cases of ligament injuries, I'm not talking about bony fractures, I'm talking about ligament injuries, we need to get some optimal loading. We need to get loading in the system. As soon as we get loading in the system, the collagen that gets thrown down by the body is now going to be forming in nice structural strips rather than like a bowl of cooked noodles, which is what will happen if we have unloaded. So police is protection, optimal loading, ice compression and elevation. Rest is gone. Unless it's bony fracture, okay, rest. But if it's non-bony fracture, not a bony fracture, then we want to have our optimal loading. And this will encourage healing. So let's have a look at some systematic reviews to back any of this up. Majority of grade 1, grade 2, and grade 3 ligaments can be managed without surgery. For non-surgical treatment, long-term immobilization should be avoided. We need optimal loading. For grade 3 injuries, a short period of immobilization, maximum of 10 days, when using a walker. So it says immobilization, but perhaps still with load, to get that optimal loading into the system. After this phase, we are needing to protect the ankle against inversion, and for that, we can start to consider ankle bracing. Even grade 1 and grade 2 injuries are can be effectively treated with a semi-rigid ankle brace. So this particular systematic review is actually recommending ankle bracing even for grade 1. So I'm now going to talk a little bit about walkers, because we've seen walkers in every presentation so far. And we can get better clinical outcomes when using walkers over traditional immobilization. And there's been a number of papers, quite old, some of these, which show better ankle function, earlier return to full weight bearing and daily activities, speeds up functional recovery and return to work. But walkers, well, obviously today we've only got one walker that's on show. But I had great fun going round conferences, and the number of variations of walker that you get is immense. Everybody's got some kind of walker. And I thought, well, what's the difference between? Are they any different? Are they all the same? And at this point, I have to say, I got paid nothing for a DJO or Enovis for doing this work. Okay, I get no money. I mean, I even have to fly economy. Okay, so so if we think about what we wanted to do, I wanted to look at whether or not the different designs of orthotic walker were any different at all. Now, many walkers vary very subtly in terms of design. And there's two aspects of the design which is really fascinating. One is rocker profiles and one is tibia angles. So rocker profiles, this is a paper that we did, oh God, I can't remember how long ago now. This was probably 2012 or something, where we looked at a number of different just shoe rocker profiles and looked at what happens with different rocker profiles. Rocker profiles will change lower limb biomechanics. And these are trying to promote a better, easier walking pattern. If you have a completely flat shoe, rigid, there's no way you can then bend your metatarsals. There's no way you have any functional movement there. So the functions of the rocker are to provide a compensation for the loss of motion at the foot and ankle. That's what we are using rocker profiles for. We need to look at these in terms of overall gait improvements, deformities, joint stiffness. These are all areas where we are using rocker profiles. Provide relief from and redistribution of plantar foot pressures. This is another reason for using different rocker profiles. And it also influences lower limb biomechanics and muscle activity. So that's one aspect, is the rocker profile. The other aspect is the tibia angle. And I'm now going to steal something from looking at ankle-foot orthoses in cerebral palsy. You're thinking, where on earth is he going with this one? So I'm now going to think about the tibia angle for trying to get ease of movement or ease of walking. And we can look at what we refer to as shank to vertical alignment. And all of this was in a paper in 2010 by Elaine Owen, who runs a number of cerebral palsy services to actually optimize ankle-foot orthoses. So this is our ankle-foot orthosis, and we've got this shank vertical angle. So what we're wanting to do is to get the tibia progressing forwards. This isn't the ankle, this is just the tibia progressing forwards. If that tibia progresses forwards well, then you're able to walk easily. If you cannot progress your tibia forwards, it's almost impossible to walk. And this has all been done many, many, many times before with ankle-foot orthoses. If the tibia angle is wrong, then we create a huge problem at the knee and also at the hip. So if the shank to vertical angle is incorrect in a non-tuned ankle-foot orthosis, we're going to cause problems at the knee. And what we really want is between about 5 and 8 degrees of tibia inclination forwards, which then allows us to move forwards really nicely, really easily. And this has a dramatic effect on the knee extension moments in ankle-foot orthoses. So what happens if we now think about orthotic walkers in the same way? This is two walkers. Do they look the same? Well, we get different positions or profiles of the heel rocker. We get different profiles of the toe rocker. All of this will affect the biomechanics. Oh, you want to take a photo? There you go, take a photo. What about the tibia angle? If we draw a line straight up here, this looks like it's pointing backwards. whereas this one looks like it's pointing forwards. Which one's going to be easier to walk in, do you think? Okay, the one with the shank angle going forwards. So we have all these measurements that we can take, and we can now look at walkers in a different way. So I'm now going to show you some work that we had published a few years back, where we compared normal walking with an Aircast walker and an Ossur rebound walker. I won't bore you with the boring bit of data collection, but we collected lots of lovely kinematics, movement analysis, and we wanted to look at the hip and knee kinematics and kinetics and see what was going on with the movement and the forces. So here we go. We've got somebody walking, and they're going to walk in one of these and walk in one of these, and we're going to see what's going on with all the biomechanics. So what do we see? Well, we see significantly greater knee flexion than the Aircast walker, but also walking without the walker, we get a difference as well. So there seems to be a bit of a staged effect here of there to there to there. So we get also a significant increase in the transverse plane range of motion. So not much difference here, but significant difference here. So we are seeing more rotation. Now, we don't really want rotation, more rotation. This is a compensation mechanism that we don't really want. So the knee angles are quite interesting that we're seeing these changes. But that's not where we get the biggest changes. The biggest changes we get when we start to consider all the forces and the moments going up the lower limb. So what happens here is we get our flexion moment. So we get a much greater flexion moment. So we're putting much more load at the knee with one walker over the other because of its tibia angle and because of the rocker profile. Significant increase in knee extension. Okay, this is where it gets really interesting, because this is exactly what we see in the cerebral palsy with the ankle-foot orthoses. As we have a better rocker angle or tibia angle, we are reducing the knee extension moment. This is going to try and hyperextend the knee. Now, if the person's had some ankle injury, there could be a chance of a bit of knee injury as well alongside that. It's not unreasonable to suggest that. So anything we can do to protect the knee would be a good thing. And this is what this looks like in one particular individual. This is normal walking, this is the Aircast walker, and this is the other walker, the rebound walker in this case. So we're seeing this horrible hyperextension moment, which is not going to be good, and that's down to the design of the walker. So if you are looking at walkers, I want you now, every time you see one, look at the tibia angle, look at the rocker profiles, because they are different. What this physically looks like is here the ground reaction force is slightly in front of the knee. Here it's way in front of the knee. And that's going to cause lots of trouble with that person walking. And the ease of walking is much harder when you are dealing with this walker here. Hip also matters. So we also have differences in the hip strategy. So again, I know this is meant to be an ankle, but we need to think about what is going on when we are managing. And we want to get ease of movement. If it's easier to walk, we get more optimal loading. We get faster recovery. So what we're seeing here, again, is that one walker is showing very different results to the no intervention. So rocker profiles and tibia angles matter in walker design. So in conclusion, we need to ensure that we have correct short-term immobilization, but with optimal loading. Optimal loading will give us our faster recovery and allow us to move on to the next stage of the management and rehabilitation. And the next talk I'm going to give is going to be focusing on that longer-term management of ankle injuries and also protection and prevention of future ankle injuries. So see you soon. Thank you very much for listening.